clinical conditions involving abnormalities in fluid volume or electrolyte composition where diuretics are used. Classify diuretics according to their sites and mechanism of action. Describe the pharmacokinetics and pharmacological actions of diuretics. And lastly, describe the potential adverse effects and their therapeutic applications. Okay, so are you familiar with the term diuretic?
Yes.
What does it mean by diuretic? We also call diuretic as water pills. So what is diuretic? Huh? It's an agent that promotes urination, kan? Promotes urination or voiding, promotes water loss and sodium loss from your body. Can you name me some of the natural diuretic that you know? Huh?
Antidiuretic hormone.
Common natural diuretic. Apa? Contohnya caffeine, kan? Don't you think that when you take caffeine you go to the toilet more often? Kan? Caffeine such as coffee, tea, lagi apa? Watermelons. So there are some natural diuretics juga, kan? So today we are going to focus on diuretic agents. Okay, so before we move further, this is the important part of regulating of playing the mechanism of action of diuretic. Your nephron. What does it mean by nephron? It's a functional unit of the kidney, kan, which comprises of your renal corpuscle, which is the glomerulus, and your renal tubules. And this nephron plays important role in your renal physiology, which comprises of what? Filtration, reabsorption, secretion, excretion. So ingat lagi tak each of the steps, what happened in filtration, what happens in renal reabsorption. If you can't remember those, you cannot understand the mechanism of action of diuretics very well. So you can recap balik your renal physiology, yeah. Okay, so let's have a look. Let's have a very quick recap on your renal physiology. What happens in each of the tubule? I tak nak sentuh filtration lah. Which filtration happens in your glomerulus, kan? So diuretics mainly plays a major role in each of your tubule, renal tubule cycle, which start with the proximal tubule. Okay, in proximal tubule, and as you know, you ingat lagi tak, as you move further, it becomes more permeable ke impermeable to water? Makin lama makin jauh makin impermeable to water, kan? So this is the first renal tubule, which is the proximal tubule. About 60 to 70% of sodium and water reabsorption occur here, and the most important mediator in proximal tubule is your Ca, carbonic anhydrase. This plays a major role in regulating whatever process that's happening in your proximal tubule. Ingat lagi tak semua ni? Ingat tak gambar ni? Pernah belajar, kan? So this is just a recap for you, Okay, so when sodium enters the cell, this will happens in exchange with hydrogen ion. Hydrogen will combine with bicarbonate to form bicarbonic acid, and then carbonic anhydrase ni, this is an enzyme, carbonic anhydrase will dissociate bicarbonate acid into water and carbon dioxide, and it will enter the cell, and then this will carbonic anhydrase will again form bicarbonate acid and then dissociate again into hydrogen and bicarbonate. So this is a simultaneous process lah. It will be repetitive. It's a repetitive process, and then bicarbonate will be reabsorbed into the blood. So basically paling banyak kat sini lah 60 to 70% of sodium bicarbonate and sodium chloride reabsorption, yeah. Okay, and then next is your, what is this? Loop of Henle. Okay, thick ascending limb of loop of Henle, and the most important co-transporter here is NKCC2, sodium potassium 2 chloride co-transporter. And at this site, about 25 to 35% of sodium chloride reabsorption is happening in your loop of Henle. And when sodium potassium chloride enter the cell, this will drive potassium. When there is too much potassium, this will drive potassium out of the lumen, and then This electrical potential will drive reabsorption of other ions such as magnesium and calcium. So in the loop of Henle ada reabsorption of magnesium and calcium as well, yeah. Okay. And then your DCT. So DCT pun dah makin impermeable to water. Only about 10% of sodium chloride and water is reabsorbed here. And the most important co-transport here is NCC, sodium chloride co-transporter. Okay. And then kita ada juga calcium channel, which will drive calcium reabsorption with the help of PTH here. So okay. So basically dekat distal convoluted tubule ada calcium reabsorption jugalah macam your loop of Henle. Okay. And then the last side here is your collecting tubule, ada epithelial sodium channel. The action of ENaC ni is stimulated by aldosterone. What is the function of aldosterone? It promotes sodium reabsorption and potassium secretion kan. So they will stimulate ENaC to reabsorb more sodium, and then potassium will be diffused out of the cell. Okay. Collecting tubule is the most important site for potassium secretion, yeah, compared to other tubules. For collecting tubules ni paling penting is the potassium, yeah. Okay. So at the CCT ni, collecting tubule about only 2 to 5% sodium chloride reabsorption. Okay, so you ingat balik your renal physiology in each of the tubule, barulah lepas ni you boleh faham ya how does each of these diuretic works ya. Kita classify diuretic agents based on the site of action. Okay, contohnya we have carbonic anhydrase inhibitors. Where do you think this exert the effect? Yes, proximal tubule, and then we have loop diuretics, which of course exert the effect on your loop of Henle, and then we have thiazide, which exert the effects on the DCT, and then potassium sparing diuretics. Nama pun potassium sparing, which I ada emphasize tadi dekat collecting tubule. Collecting tubule plays a major role in potassium regulation. So potassium sparing diuretics plays a role in the collecting tubule. So senang nak ingat diuretic agents ni based on the site of action. So you boleh ingat the mechanism of action easily. Okay, and then we also have osmotic diuretics and some of the newer drugs lah, SGLT2 inhibitors and adenosine A1 antagonists, which is not so commonly used compared to other diuretic agents. Okay, so let's go into detail one by one. The first is carbonic anhydrase inhibitors. The example, only one example of this class, acetazolamide, or the brand name is Dimox. The mechanism of action, you ingat the physiology effect of your renal tubule tadi, you boleh ingat the mechanism of action. The effect of this drug will oppose the effect of your renal physiology. Macam contohnya acetazolamide ni, it blocks the CA, blocks the carbonic anhydrase. So what happens when your carbonic anhydrase enzyme is blocked? It will inhibit bicarbonate reabsorption at the proximal convoluted tubule. So what happens when your sodium bicarbonate is reabsorption is inhibited? What happens to the blood? More bicarbonate will be lost in the urine kan, so the blood will be more acidic kan. So this, when you take acetazolamide, you are prone to developing metabolic acidosis if you take too much acetazolamide. Okay, so when do we use carbonic anhydrase inhibitors? Okay, for example, in glaucoma, to inhibit secretion of bicarbonate from blood into aqueous humor, to reduce aqueous humor formation. Tapi glaucoma ni kita ada banyak lagi agent to treat glaucoma, so carbonic anhydrase is not the first line treatment lah. Okay, you dah belajar pasal glaucoma kan, and I also have included a table of examples of glaucoma treatment. This is just one of the agent to treat glaucoma lah, but not the first line. And then it can also be used for urinary alkalinization. For example, in some patients, especially those who have problems with the kidney, any renal conditions such as kidney failure, Apa lagi? Renovascular hypertension, any problem related to the kidney lah. They are prone to have acidic urine, and acidic urine ni prone to stimulate formation of kidney stones, ya. Ingat tu, acidic urine in some people prone to cause formation of kidney stones and then formation of uric acid, cysteine. So in this kind of people, kita boleh bagi carbonic anhydrase inhibitor to make the urine more alkaline. So when the urine is more alkaline, this will enhance the excretion of the kidney stones and enhance the excretion of cysteine, uric acid, semua tu lah. Okay. And then in metabolic alkalosis, sebab dia inhibit reabsorption of bicarbonate kan, so promotes more bicarbonate loss, so boleh treat, kita boleh guna untuk treat metabolic alkalosis to make the blood more alkaline. And then for acute mountain sickness, those climbers, they take carbonic anhydrase inhibitors as prophylaxis, because those climbers, they are prone to have sudden drop in the blood pH. The blood pH become very acidic, so they will tend to have problems with the respiration and so on. So kita boleh bagi the climbers ambil this acetazolamide as prophylaxis to prevent this acute mountain sickness lah. Alright, to maintain and stabilize the pH, okay, the blood pH. Okay, the adverse effect of carbonic anhydrase inhibitors, metabolic acidosis lah, sebab promotes more bicarbonate loss from the blood, so blood become more acidosis, and then potassium wasting. It can cause hypokalemia. So when there is less potassium in your body, it can cause paresthesia or muscle wasting, muscle problem lah, muscle weakness. Okay. Alright. Next diuretic is the loop diuretics, Example of loop diuretics are furosemide, torsemide, bumetanide, anticholic acid. Usually I akan susun the drugs according to the most commonly used lah, and the most commonly used is Lasix or furosemide, The mechanism of action of diuretic, it inhibits, you kena ingat the most important mediator or the co-transport in each of the tubules. So you boleh ingat the mechanism of action. Macam loop diuretic, dia akan affect your NKCC2, sodium potassium 2 chloride co-transport, NKCC2 in the thick ascending limb of loop of Henle. So by inhibiting this NKCC2, this will inhibit or reduce the sodium chloride reabsorption. So when you reduce or inhibit sodium chloride reabsorption, you akan reduce juga the electrical potential that drives magnesium and calcium reabsorption. So you inhibit juga magnesium and calcium reabsorption. So you promote more calcium and magnesium loss. So jadi hypocalcemia, hypomagnesemia, okay? And then this loop diuretic, it has direct effect on the renal blood flow as well, sebab dia ada dekat your kidney ada prostaglandin. So loop diuretic ni can affect your prostaglandin directly. Sebab tu you tak boleh bagi loop diuretic with the drug that affect prostaglandin. For example, NSAIDs. NSAIDs ni pernah dengar ke NSAIDs? Kan nanti kita akan belajar NSAIDs jugalah. So NSAIDs such as ibuprofen, apa lagi, Celebrex, semua tu kita tak boleh bagi together with loop diuretics. It will affect the efficacy of loop diuretics. Okay, so of all diuretic, loop diuretic is the most effective diuretic agent lah, because it does not cause any metabolic alkalosis or metabolic acidosis into your body. So and it is also known as high ceiling diuretic. Kalau orang cakap high ceiling diuretic, maksudnya loop diuretic lah, the most effective diuretic agent. Okay, pharmacokinetic, it is rapidly absorbed, it has good absorption. So basically the main practice is we give per oral lah. We only give IV at the clinical setting for emergency saja, but the usual practice is always per oral. Okay, clinical applications of loop diuretics for edematous conditions such as pulmonary edema, for hyperkalemia to promote more potassium loss, for acute renal failure because it can increase urine flow rate and flush out CAS, and anion overdose to flush out anion such as bromide, fluoride, iodine. Sebab loop diuretic ni dia boleh promote other anions loss lah. Okay, and then adverse effects, senang nak ingat adverse effects of loop diuretics. O is ototoxicity. H ni besarkan sebab senang you nak ingat. H banyak ya, hypokalemia, hypomagnesemia, hypokalsemia. Basically all diuretics cause hypokalemia except potassium sparing ya. Semualah carbonic anhydrase pun boleh cause hypokalemia. Loop diuretic pun hypokalemia. Okay, and then D for dehydration, A for allergic reaction, N for nephritis, and lastly G for gout. It can stimulate production of uric acid, so causing hyperuricemia. So you have to be very careful in prescribing loop diuretics to patient with gout. Yeah. So ingatlah loop diuretic side effects or adverse effects is okay. Senang nak ingat. Next we have thiazide, the third diuretic which acts on your DCT. Yeah. It's a type of sulfonamide derivative, so you cannot give thiazide to any drugs that derive from sulfonamide. For example, some types of antibiotics lah. Okay, you tak boleh bagi sulfonamide. Together with sulfonamide, it can cause a very severe allergic reaction or anaphylaxis. Okay, example of thiazide: chlorothiazide, hydrochlorothiazide, metolazone, indapamide, and chlorothalidone. Okay, mechanism of action: it blocks NCC, the most important transporter in the DCT. NCC, sodium chloride co-transport. Okay, so by inhibiting NCC, this will reduce reabsorption of sodium chloride. But in contrast to loop diuretic tadi, loop diuretic dia inhibit calcium reabsorption kan. So inhibit calcium reabsorption, more calcium will be lost in the urine, so jadi hypocalcemia. Tapi thiazide ni dia ada calcium channel ni, and dia ada PTH sini, dia akan increase calcium reabsorption and it can cause hypercalcemia ya, instead of hypocalcemia. So jangan tertukar ya, loop diuretic causes hypocalcemia, thiazide causes hypercalcemia. Okay. Alright, so basically all thiazide ni has a good absorption lah, and all kita bagi oral. Only chlorothiazide is available via IV, yang lain semua tak ada IV, semua kita bagi oral. Only chlorothiazide is available in IV form. Okay, clinical applications kita boleh bagi for hypertension, heart failure, nephrogenic diabetes insipidus, and renal stones due to hypercalciuria. So bila patient ada renal stone due to hypercalciuria, kita boleh bagi thiazide to increase calcium reabsorption into the blood to reduce the calcium in the urine. Okay, faham ya? The adverse effect, tengok ni semua thiazide, like I said, semua thiazide causes hypokalemia, then hyponatremia, and then you boleh ingat juga lah thiazide can cause hyperglu. G for hyperglycemia, L hyperlipidemia, U hyperuricemia, C hypercalcemia. Okay, thiazide ni dia boleh cause hyperpolarization of your beta cells and stimulate more insulin release, so it can cause hyperglycemia. Tak boleh bagi thiazide to patients with diabetes, bukan tak boleh, but kalau boleh elakkanlah. Alright, those who have diabetes is contraindicated to take thiazide, and those with hyperlipidemia as well. Kalau you tahu patient tu ada hyperlipidemia, please choose other agents if other agents are available. Okay, thiazide indication, CHIC. Okay, congestive heart failure, hypertension, insipidus, calcium calculi. Alright, next we have potassium sparing diuretics which act on your CCT, collecting tubule. For example, spironolactone, triamterene, amiloride. Nak ingat macam mana? The potassium stays, STA, spironolactone, triamterene, amiloride. Okay? Okay. So in contrast to other diuretic agents, semua diuretic agents yang ada sebut tadi, carbonic anhydrase inhibitors, loop diuretics, thiazide, they all cause potassium loss kan, hypokalemia. Tapi this one nama pun potassium sparing, they spare the potassium in your body. How does it work? The mechanism of action, it will inhibit aldosterone. Sebab dekat collecting tubule ada aldosterone kan, so ingat balik apa function aldosterone. It will oppose the effect of aldosterone, inhibit aldosterone action. So what happens? It will inhibit sodium reabsorption and it inhibit potassium secretion kan, sebab tu dia spare the potassium in your body lah. Okay. And then for that is for spironolactone. For amiloride and triamterene, they inhibit sodium influx directly through INAC ni, epithelial sodium channel. They inhibit this INAC. Okay. Spironolactone is a type of synthetic steroid, so it can affect your hormones lah. That's why dia punya adverse effect salah satunya is kalau tengok kat sini, gynecomastia is a type of synthetic steroid, so it can cause adverse effects that related to your sexual hormones. Okay. Clinical uses of potassium sparing diuretics can treat mineralocorticoid excess and hyperaldosteronism when patient has too much or too active aldosterone. For example, in patient with Crohn's disease, cirrhosis, nephrotic syndrome. Okay, we use potassium sparing diuretics in conjunction together with loop and thiazide lah. Selalunya potassium sparing ni kita tak bagi as single agent lah, selalunya kita combine with other type of diuretic. Okay. Adverse effect, hyperkalemia. So when there is hyperkalemia, it can cause muscle weakness as well, or paresthesia. Okay, and then gynecomastia, kidney stones. Okay. So this is just a figure for you to remember about spironolactone. Too little or too much potassium will cause weakness in the muscle, including the heart. So potassium memang very important for your muscle function, yeah. Okay. And then we have SGLT2 inhibitors. What does it mean by SGLT? It's a sodium glucose co-transporter 2. 90% of sodium in your body is reabsorbed by this co-transport lah, sodium glucose co-transporter. Yeah, so kita bagi sodium glucose co-transporter 2 inhibitor to increase renal excretion of glucose, to inhibit glucose reabsorption. This agent does not play so much role as diuretic lah. It's actually a type of anti-diabetic. So nanti you akan belajar in detail lah in anti-diabetic agents ya. Example of SGL2 inhibitor, dapagliflozin and canagliflozin. So ingat ni nanti you akan ingat lah lagi dalam anti-diabetics. Rapidly absorbed and excreted in the urine, contraindicated in renal failure and liver disease. Clinical uses, of course lah, the main clinical use is diabetes mellitus, but it promotes inhibit glucose reabsorption without having to interfere with sodium and water so much, so mainly on the glucose only. And then we have adenosine A1 receptor antagonist, which inhibit reabsorption of sodium and water, especially in the PCT, and it has a direct effect on the release of renin. What is the function of renin? Conversion of angiotensinogen to angiotensin, and then finally angiotensin 2 kan. So ni pun you kena ingat balik lah RAAS system tu. Okay, example of adenosine A1 receptor antagonist is caffeine and theophylline. Okay, tapi kita tak banyak guna lah as diuretic agent this one. This is just ni lah, it's not an important diuretic, just additional. And then we have agents that alter water excretion, osmotic diuretics such as mannitol, which works as osmosis lah kan. They prevent reabsorption of water from proximal tubule and descending limb of Henle. It is actually not supposedly called as diuretic, it is more as aquaretic. Aquaretic ni means agents that inhibit reabsorption of water sahaja ya. For osmotic diuretics such as mannitol ni, dia tak kacau any other solids, dia tak kacau your sodium. dia punya effect only on water sahaja. So basically it is also called aquaretic, not diuretic. Okay, clinical uses, and it has poor absorption. So osmotic agent ni is given via IV lah, mannitol. Selalunya kita bagi mannitol in clinical setting via IV to reduce intracranial or intraocular pressure, okay, during the surgery. Okay, adverse effects, extracellular volume expansion, which can lead to complications such as cardiac heart failure, pulmonary edema, nausea and vomiting. And then we have ADH antagonist. What is the function of ADH? To make the urine more concentrated kan. So kita boleh bagi ADH antagonist such as conivaptan, lithium dan meclocycline. ADH antagonist pun kita tak bagi as, never be given as first line lah, and selalunya kita bagi as conjunction with other agents as well. Okay, so this is renal to show you the side of action of diuretic in your renal tubules. Okay, therapeutic uses of diuretics, diseases requiring diuretics. Okay, the first one will go into edematous states. Okay, edematous states such as heart failure. You dah belajar pathology of heart failure ke? Belum. Alright, so generally when in heart failure patient, there will be reduced cardiac output kan. So cardiac output due to heart failure will cause changes in your BP, and when there is changes, when there is drop or rise in the BP, it will also affect the blood flow to the kidney kan. Sebab your heart and kidney plays a role together in regulating your BP, your blood pressure. So when your blood flow to the kidney is affected, it will become hypovolemia and then promote salt and water retention. Sebab tu lah in heart failure, selalunya some patients, especially the untreated patients, they develop ankle edema sebab there is salt and water retention due to this hypovolemia. So diuretics are needed lah to improve to improve the salt and water retention and eventually improve myocardial infarction. Okay, and in heart failure selalunya kita bagi loop diuretics or with addition of thiazide. Okay, and then in kidney disease pun for example glomerular diseases secondary to SLE, diabetes mellitus, this kind of patient they presented with ankle edema as well due to salt and water retention. And then for those who have diabetic nephropathy, selalunya presented with hyperkalemia. So bila ada hyperkalemia, kita boleh bagilah thiazide ke loop diuretics ke. Okay, and then those who have nephrotic syndrome pun kita boleh bagi loop diuretics and thiazide. Okay, because nephrotic syndrome can eventually cause orthostatic hypotension. Okay, and then hypertension and expanded volume ni semua kita boleh selalunya first line diuretic is always loop diuretic, and then kita boleh combine with thiazide. Okay, and if some patient develop a severe hypokalemia, kita boleh add on potassium sparing to regulate the potassium level. Okay, and then another edematous state is liver cirrhosis. What does it mean by liver cirrhosis? Scarring of the liver kan. When there is scarring of the liver, it will affect your blood flow to the liver, and then it will cause complication like portal hypertension. It will cause portal hypertension, and then when there is portal hypertension, it will cause stimulation of accumulation of the fluid in the abdomen, which is called ascites. So edema and ascites will eventually lead to water and salt retention lah. Okay, which will cause renovascular changes, diminished plasma volume, elevated aldosterone. So patients with liver cirrhosis ni who has portal hypertension, selalunya dia punya aldosterone is elevated lah. So kita boleh bagi spironolactone for cirrhotic patient. Okay, for non-edematous states such as hypertension, nephrolithiasis ni kita selalu banyak bagi thiazide lah sebab patients present with hypercalciuria. And then hypercalcemia kita bagi loop diuretics. And then diabetes insipidus, do you know what does it mean by diabetes insipidus? What is the symptoms of diabetes insipidus?
Dry inside. Tasty.
Polydipsia.
Polyuria and polydipsia kan. So kenapa? Why do you think when this patient has polyuria, dia banyak urinate kan? Kenapa kita nak bagi diuretics lagi? Ada terfikir tak? Kenapa? This is, I want you to go back and find out. Nanti we will discuss together in my next tutorial lah. Tak tahu tutorial, tapi please find out ya. I know why, but I don't want to explain now. I want you to go back and do your research. Kenapa kita bagi thiazide is one of the main treatment for diabetes insipidus lah. Tapi I nak you fikir, kenapa diabetes insipidus patient ni ada polyuria, kenapa kita nak bagi diuretics lagi? So please do your research ya. Nanti kita discuss sama-sama. Alright, so this is summary of the diuretics lah, the mechanism of action, the side effects, the uses. Okay. Alright, so let's have a look, quick look at my questions. So far faham ya diuretics? So senang nak ingat je, you kena ingat your renal physiology, the important mediators, the co-transport in each of the renal tubules, so you boleh relate with the mechanism of action. Okay, and ingat the main example of each class lah. Carbonic anhydrase inhibitor, we have acetazolamide. Loop diuretic, we have furosemide, apa lagi, bumetanide, and then thiazide, contoh thiazide, chlorothiazide, hydrochlorothiazide, and then we have potassium sparing, spironolactone, triamterene, amiloride. Senang, semua tu senang nak ingat. Okay. Alright, number 1, furosemide acts to inhibit sodium reabsorption in which of the following location? Furosemide is a type of okay, loop diuretic. So which is the site of action for this furosemide? Tak dengar? A, B, C, D. Okay, A, ascending limb of loop of Henle. A patient arrives at the ED in comatose state and has serum calcium of 4.5, which is high. So dia ada hypercalcemia. You start a saline infusion with which of the following drugs? So hypercalcemia, you nak bagi apa? A, B, C, D. I heard D. Apa? A, B, C, D. Hypercalcemia, kita nak bagi agent that inhibit calcium reabsorption. Which one? Loop diuretic ke? Thiazide ke? Loop diuretic. You sure? Loop diuretic inhibit calcium reabsorption. Thiazide? Which one? Tacrolic acid ke? Metolazone? Ingat lagi tak? Tacrolic acid is loop diuretic ke thiazide? Okay, so the answer is loop diuretic. A 65-year-old female with congestive heart failure presents with worsened symptom over the last 2 weeks. She is placed on oxygen and given IV furosemide and amiloride tablet. Okay, furosemide is loop diuretic. So what is the mechanism of action of loop diuretic? Inhibit NKCC2 kan. So by inhibiting NKCC2, dia akan inhibit sodium chloride reabsorption. And then what is the mechanism of action of amiloride? Amiloride is a type of potassium sparing diuretic. So how does it work? It inhibit epithelial sodium channel kan. So basically inhibit sodium chloride reabsorption as well lah. So adverse effect of each of the diuretic agent. Adverse effect of furosemide, loop diuretic apa? Ototoxicity, hypokalemia, hypocalcemia, apa lagi? Dehydration, allergic reaction, nephritis, gout. Okay. Amyloride, adverse effect of amyloride. Hyperkalemia. Okay, it does not cause gynecomastia. Gynecomastia only for spironolactone saja because it's a type of synthetic steroid. Any synthetic steroid, if you take too much, it can lead to gynecomastia. State the contraindication of using these combined diuretics. What can you think of the contraindication of giving furosemide together with amyloride? Apa? Fikir balik ni fikir apa? Diuretic plus potassium sparing. What are the contraindications? Okay, number 4. A patient taking an oral diuretic for about 6 months presents with elevated fasting and postprandial blood glucose level. Examinations reveal elevated HbA1c, so dia ada hyperglycemia. Which of the following drug is most likely to cause this condition? Which of the diuretic can cause hyperglycemia? Okay, thiazide. So A, B, C, D? C, chlorothiazide. Hypergluc kan, can cause hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia. Okay, a 60-year-old man with congestive heart failure has been taking loop diuretic to reduce his peripheral edema. His laboratory investigation report revealed low potassium. Which of the following diuretics will be better to use in this patient? A, B, C, D.
Low potassium.
Hello? D, yes. Trimetharin is a potassium sparing. So those who has been taking diuretic yang dah develop low potassium, you boleh change or you boleh add on potassium sparing. Or some doctors, they tak add on other drugs, they just suruh patient take potassium supplement. So that is another example to manage low potassium lah. Okay, alright, that's all. Any question?